Prof. Morgan, Dr. Anthony Clark, Dr. Mita, Dr. Firna, Dr. Dian Estu, staff from Cipto Mangunkusumo Hospital, Jakarta, and also from Perth, and all participants who attended this Zoom meeting. I'm Julie as moderator for this session, and I work at pediatric ophthalmology clinic in Cipto Mangunkusumo Hospital as a pediatric ophthalmologist. It is my great pleasure to welcome you all to this exciting webinar series of the Australia-Indonesia Joint Lecture Series. Thank you for joining us today as we continue to strengthen the bond between our countries through knowledge and collaboration in the field of ophthalmology, especially pediatric ophthalmology for this evening. In today's session, we will discuss about pediatric cataract, and we have two presentations from two speakers. First, we'll have a case presentation from one of our ophthalmology residents, Dr. Lia Amanda from Indonesia. And the presentation talk about Beyond the Haze, the hidden burden delay pediatric cataract surgery. Will provide a practical perspective on the challenges we face in clinical practice. We look forward to an insightful discussion around the case. And following the case presentation, we'll hear from Dr. Anthony Clark from Perth, who will be delivering a lecture titled Pediatric Cataract. Dr. Anthony Clark, highly respected in this field, and we are excited to learn from him, his expertise and insight. Before we begin, I'd like to remind everyone that we will have a Q&A session at the end. Please feel free to submit your question in the chat box, and we'll address as many as possible. Without further ado, we'll start with Dr. Lia Amanda. We have an exciting case presentation coming up that will give us a more practical, hands-on perspective on the topics. Dr. Lia, please start your presentation for 15 minutes.
Yes, thank you, Dr. Julie. Good afternoon, Professor, doctors, fellows, and fellow residents. My name is Lia Amanda, third stage ophthalmology residents, and it's a privilege to be here for the Australian-Indonesian Joint Lecture Series. And today I'll be presenting a case with the title Beyond the Haze, Hidden Burden of Delayed Pediatric Cataract Surgery. And I'd like to thank Dr. Julie and Dr. Estu for their guidance and feedback for this case. So I would like to start with the case illustrations. So this is a boy, 4 years old, with chief complaint with white on both eyes have worsened 6 months before the admissions. So actually at 5 months old, the parents noticed that the white pupils in both eyes with poor eye contact and inability to focus. And actually 2 years before, the parents took the patients to ophthalmologists and cataract surgery was planned at other hospital, but was postponed after the patient was diagnosed with pulmonary tuberculosis and he started treatment. And then after that, 1 year before, the parents took the patients to ophthalmologist again and then referred to our hospital for further evaluation and treatment. And 10 months before, the patient actually was planned for surgery at our hospital, but on the day of the operations, the patient had cough, runny nose, and high fever, so the surgery was postponed and requiring condition optimizations. Actually, the patient was not really regularly controlled to our clinic, so he lost follow-up, and then 2 months before, the patient come again to our clinic and with complaint of more noticeable white pupils, difficulty focusing to see objects around him, and frequent falls. And the patient was planned for cataract surgery at our hospital. And other previous medical history, the patient was third child, history of spontaneous birth at midwife clinic, and he only got diagnosed with pulmonary tuberculosis with complete treatment for 9 months. And there were no any prominent previous medical history. So here are the ophthalmological status for the patient. So when the patient came to our clinic, there's a nystagmus with exotropia. So for the visual acuity of the patients, he only can following light but cannot following the object with normal intraocular pressure with deep anterior chamber. And as you can see that the lens is very hazy, whitish, and the same as with the left eye, with the lens with hazy and so whitish. So we also did the ultrasonography of both eyes, and we found that the USG of both eyes with features clear, retina touch, and nerve 2 intact. So we assessed this patient with infantile cataract of both eyes with exotropia and sensory nystagmus. So we plan to do the extraction of the cataract, and we also plan to do posterior capsulotomy, vitrectomy anterior, and insertion of intraocular lens of both eyes. And we try to plan to do surgery for right eye and then the left eye. So these are the intraoperative video. The operating surgeon is Dr. Julie. So at first we did the clear corneal incisions, patients, and injection intracameral adrenaline. And then we using the Trifon Blue intracamerally. And actually at first we did the CCC with cystotomy using a can opener technique at first. And then, but since the anterior capsule was very fibrotic, and then we tried to cut it using Panna scissor and vitrectomy scissor. And then we did irrigation and aspirations of the lens. And then we tried to make sure that there was no retaining lens mass behind the iris. And then we tried to do polishing, and then we tried to do making posterior capsulotomy for these patients. And then we did the vitrectomy anterior around the PCC to making sure there's no vitreous remaining in the anterior chamber. So we insert the intraocular lens. We use 3-piece IOL for these patients. So after that, we did the vitrectomy anterior again to making sure any remaining vitreous in anterior chamber and injection of bubble. We're making peripheral iridectomy and then closing the wound using the vicryl sutures and then closing injection the antibiotic. So this is the ophthalmological status post-operatively day 1. So for the intraocular pressure, it's 17. As you can see that the cornea was quite edema with deep anterior chamber, von Herrick 4 with cells plus 3 flare plus with bubble at scoria, but the lens is not quite clear, but it's a central. So we give the antibiotic eye drops to this patient, prednisone eye drops and methylprednisolone orally, and also antibiotics orally for the patients. And then 7 days after, 1 week after the surgery, these are the ophthalmological status for 7 days after the surgery. As you can see that the visual acuity for this patient still following light but no following object with intraocular pressure is 18. With the cornea, as we compare to before, that is quite clear, and the deep anterior chamber von Herrick 4 with cells plus 1 with the lens central, but we found that there was a membrane formation in front of the lens. So we still continue the antibiotic eye drops, prednisone eye drops, and also methylprednisolone orally to these patients. So I will continue with discussions. So as we know that the pediatric cataract is a treatable childhood blindness, especially common in developing countries. And untreated pediatric cataract can have significant social, economic, and emotional impacts on the child, their family, and society. And in ophthalmology, early identifications, diagnosis, and management of this condition is a key challenge. And late diagnosis can lead to the symptoms like nystagmus, poor fixations, and strabismus. And for the prevalence of pediatric cataract itself, globally, pediatric cataract contribute to 5 to 20% of childhood blindness and severe visual impairment with incident rate 1.8 to 3.6 per 10,000 children annually. And for the prevalence, 1 to 15 per 10,000 children. But in one systematic review and meta-analysis in 2020, they tried to collect data from in Asia with 35 studies from 12 countries, and they found that the prevalence is 3.78 per 10,000 children, with the highest Cambodia, Vietnam, Nepal, with the lowest is in Indonesia, Bangladesh, and Iran. but high heterogeneity, maybe due to the varying study design, methodology quality, maybe such as study population, sampling methods, and study settings. But they include one study from Indonesia, from Muhir et al., and it's only give prevalence from certain areas in Indonesia, in Sumba and Yogyakarta, with prevalence of 0.6% per 10,000 children. So actually, there are several factors affect the visual outcome in pediatric cataract surgery. One of them was early diagnosis and treatment, type of severity of the cataract itself, surgical and post-operative management, visual rehabilitations, and also long-term monitoring. So actually, delay in pediatric cataract surgery from other study from Kokar et al., the major causes of surgical delays in pediatric cataract surgery cases in India include long general anesthesia waiting time, systemic ill health of the child, parents seeking a second opinion, and parental reluctance to proceed with surgery. And they also, another study also found that identified several factors that contribute to better visual outcome. These include younger age at the time of the surgery, higher socioeconomic status, shorter delay between symptom recognition and healthcare presentation, and better preoperative visual acuity. And these are the challenges that we found in our cases. As we know that in our case, the cataract was total haziness and with otis, and as it is described in other study, and these are associated with worse final BCVA due to the severe obstructions of the visual stimuli. And also the delayed cataract removal in this patient may lead to stronger suppressions and adverse effect on binocular visions. And since this child had tuberculosis, TB, and this is the reason why he is postponed the surgery, and due to systemic ill health that he had. Also, it's linked to poor visual outcomes due to the late timing of the surgery. And we also found, since we found the fibrotic anterior capsule during pre-operatively, so it make us, and it's so challenging to perform CCC using conventional methods. And we also found membrane formations in these patients, maybe due to it, intense post-operative inflammatory response in young children. So in conclusions, these are the take-home messages. Actually, timely diagnosis and early intervention lead to better prognosis. And actually, optimizing a child's systemic health may lower post-operative inflammations and may also pediatric cataract surgery requires complete facilities, skilled surgeons, and also effective visual rehabilitation planning. And continuous and ongoing post-operative care is very essential after the cataract surgery itself. Thank you.
Okay, thank you, Dr. Lia, for the excellent presentation. The case presented by Dr. Lia is only one example of the many patients whose surgery was delayed due to late diagnosis, delay in surgery for various reasons, such as financial problems maybe, and this resulting in a poor visual prognosis. Delays in cataract surgery will also make it difficult for us as surgeon to perform surgery well, such as difficulties during anterior or posterior capsulectomy due to the condition of fibrotic lens capsule, and difficulty in aspirating lens mass that are already harder. And another problem that often arises is how to manage the vitreous so that it doesn't prolapse anterior continuously. We have Dr. Dian Estu here. She's also a consultant in pediatric ophthalmology. Dr. Estu, can you share your experience regarding pediatric cataract cases that were delayed in surgery?
Thank you, Dr. Julie, for the opportunity. As we all know that I think many patients come to our clinic with so many reasons for not coming to hospital earlier, because maybe they were afraid about the surgery itself, because the child is still they still think that child is a child, so surgery is not common for pediatric patients. So sometimes they likes to hold to do the surgeries, although some doctors already suggest to do the surgery for the patients itself. So and also about the lens. So many I mean the IOL implantation. Sometimes patient also still confused about how do the IOL inserted into the eye. What about the glasses on and so on? So it more like to the post-operative care, but about after the surgery. So sometimes they still confused, and also maybe some myths in our country still exist in some region, maybe about doing the surgery for children. So sometimes it makes the delay for the surgery becomes higher in our country. And also maybe the measurement for the IOL implantation for patients in some hospitals maybe that is not complete. So maybe for IOL measurements or for the biometry, sometimes not many hospital has the complete biometry examination. So because sometimes we have to do the biometry in general anesthesia, they don't have the 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 machine. So so the doctors also refer the patients to the maybe national hospitals. And also maybe in our country is assisted consisted with many archipelagos. So maybe some patients hesitate to come to national hospital because of the financial problem and the transportation problem. I think that's all. Dr. Julie makes the hidden burden of that pediatric cataract surgery in our country. Thank you.
Thank you, Dr. Estu. And I hope for comments and suggestion from Dr. Clark also after you deliver your lecture, Dr. Clark. Yeah, okay. Now, as we move forward, I'm honored to invite Dr. Anthony Clark to begin your lecture. The time is yours.
Great. Thank you so much. That was a great case, Amanda. And it just shows how important it is to pick up these cataracts early in young kids to improve their visual outcomes. Basically, my discussion today is on pediatric cataract. I'll start with a brief case that highlights some important things that we should be thinking about in pediatric cataracts. Look at the different types of cataracts and their causes, and what we would suggest in terms of working up kids who present with the congenital cataract. And then look at some briefly look at some of the important issues and considerations we might be looking at when considering surgery in these children. So to start off with an interesting case, this was a child I actually saw in Canada. It was a 2-week-old boy who was in the NICU in Toronto's Sick Kids Hospital, and he's referred to the clinic because he had white pupils. He was admitted after birth with a persistent pulmonary hypertension with a patent ductus arteriosus and atrial septal defect. He was also being worked up for a sepsis of unknown source. And he had some head calcifications on head ultrasound as well. He was born at term. There was some gestational growth restriction that was noted prenatally. His parents were of Indian descent and had immigrated to Canada 3 years. They weren't related to each other. This was the photos of the child's eye, and that was the child's right eye, which shows quite a dense nuclear cataract in the right eye, and a similar appearance in the left eye. Clinically, exam findings at the time showed he had quite a small corneal diameter, so his corneal diameters were less than 10 millimeters. His intraocular pressures were normal. B scans didn't show retinal detachment, and his axial lengths were actually quite small as well, at 16.2 millimeters of mercury on the millimeters on the right, and 14.8 millimeters on the left. So it's a child with sort of bilateral nuclear cataracts with small eyes or microphthalmia. We managed to get some gonio pictures nicely on the RETCAM, which shows the angles with quite a sort of indistinct angle appearance there, with quite prominent iris processes as well bilaterally, suggestive of an anterior segment dysgenesis almost, or immature angle. So the workup for a child like this, essentially you want to take a family history. Cataracts are often inherited, and examining parents is often quite helpful as well. So if you ever presented with a child with bilateral cataract, it's very important to examine the parents, because that can often lead you in the direction of a dominant condition. But also it's very important to rule out metabolic and infectious causes in infants who present with bilateral cataract. And so this child had a metabolic as well as a maternal infectious screen with a tortuous screen. They had some urine as well. We look for amino acids and reducing substances for certain conditions like Lowe syndrome. Hyperphosphatemia and hypercalcemia can be associated with cataract as well, so they had cataracts done. The genetics team reviewed the child and family, and also they had a pediatrician review. Obviously, they were under the pediatrics team in the neonatal unit. So when we looked at their infectious workup, they came back positive for HSV IgG, which is most likely maternal. IgG in infants is most likely to come from the mum. They also turned up rubella positive as well, IgG as well. So it's difficult to know if that's from the mum or if that's it's unlikely to be from the neonate. We'll go into that a little bit in detail more later. Their CMV titers were serology was negative. Again, they had maternal IgG positive for parvovirus, but IgM was negative. Toxoplasma was negative. Syphilis was negative, and they had a CSF as well because of the calcium in the brain, which was negative as well. A metabolic screen was negative, so there's no urinary amino acids to suggest a Lowe syndrome, and the reducing substances to suggest galactosemia was normal, as well as their calcium and phosphate. And they had an MRI, and interestingly, they actually just excluded this cerebral calcification that was suggested on the ultrasound. So the child underwent bilateral sequential cataract surgery, and the standard in Toronto was to perform lensectomy without intraocular lens, generally around for 6 weeks. For bilateral cataract surgery, it's around about the 6 weeks of age to try and balance that risk of amblyopia versus glaucoma. And at the request of the infectious diseases physicians, lens material was actually sent off for PCR testing. Once the lens was out, this was the view of the fundus, which shows an interesting appearance where you can see some pigmentary retinopathy with some atrophy of the macula and sort of almost a salt and pepper appearance to both macula, which leads us sort of towards a certain diagnosis. Hopefully you're all thinking about the same thing as I am. 4 weeks later, they had another examination under anesthesia, and the standard is to review the child, and they have a contact lens fitting done under anesthesia and measurements done. And at that time, the pressure was up. The eye had actually increased 0.5 millimeter in size in corneal diameter, and the increase in axial length was about nearly 2 millimeters. Their cornea had thinned slightly as well. So the suggestion was that this was an increasing axial length and likely, and with increased pressure, which is likely an element of glaucoma developing as well, which we're concerned about, along with pigmentary retinopathy. And the PCR came back with rubella. And the child had auditory testing, which showed sensory and neural hearing loss. So to talk about rubella, it's becoming less common. The common name for it in European society has been German measles, after the person who first described it, de Bergen and Orlo in the 1750s. It's a single-stranded RNA virus. It's transmitted person to person, typically has an incubation period of about 2 weeks, and you get a viremia around about a week after inoculation, and you're infectious for about 1 to 2 weeks after you develop the disease, the symptoms of the disease. You develop a rash, and the viral shedding typically attenuates after you develop that rash. And we've had a vaccine for rubella since the 1970s. So this is the typical appearance in a child. You probably don't see this very much nowadays, but you get this typical sort of macular papular rash. The child's often mildly symptomatic with it. They're not usually that unwell. They might have a low-grade fever. Sometimes they get conjunctivitis and a sort of coryzal runny nose sort of symptoms. They may have some lymphadenopathy and some mild joint aches associated with that. But generally, it's a fairly low-grade sort of infection. The issue in terms of congenital infection was sort of brought up first by an Australian ophthalmologist, Sir Norman Gregg, and he was the first person to sort of link the teratogenicity of rubella with congenital cataracts in the 1940s. And he described the syndrome of congenital rubella syndrome, which was sensorineural hearing loss, cataracts with also associated with height defects. The theory is that so rubella is transmitted to the fetus via hematogenous spread via the placenta. Is certainly, it's not quite sure of the mechanism, but it's certainly cytopathic to certain cells and blood vessels within the body. Infectious rates are typically highest in the first trimester and also again in the later on in pregnancy. The mid-trimester doesn't seem to be as infectious, but the risk of congenital rubella syndrome, which we've described in that case, is really in that first trimester and into the early second trimester. Because the vaccine that we have for rubella is a live attenuated vaccine, it's contraindicated in pregnancy. So really, mums need to be immune before they become pregnant, because you can't really immunize them after they become pregnant. Look, fortunately in Australia, it's pretty rare since rubella vaccine has become pretty commonplace now. So in the last sort of 30 years, we've only had like 20 cases. In Indonesia, I don't have exactly the same graph, but you have slightly sort of delayed reduction in the rate of rubella. But if you look at the 3,000 per 30 million is around about 10 cases per million, which is the Australian equivalent in the 90s. So it's since the introduction of widespread rubella vaccine, that rates have dropped off quite dramatically, which is nice to see. So the associations we see with rubella in the eye, well, obviously there's cataract, but also glaucoma has got a strong association, as well as pigmentary retinopathy, microphthalmia, iris atrophy, Fuchs heterochromic iridocyclitis is another association that we see as well. We diagnose it through identifying the virus in various blood body organs, including nasopharyngeal swabs. You can find it in the blood. In this case, we found it in the child's lens material, but any sample that you can take. Serology is a little bit limited because you can't really detect it in the first month, and it takes a while for it to increase for the IgM to increase over time. And really the infant-specific IgG is going to be higher because of maternal, but what you can look for is a decrease in the IgG level, which would suggest that the child's own sort of endogenous IgG production is keeping that up. So that's another little clue if you're looking at serology. I'll just whip through that. So that was a nice little case that just shows that we should always be thinking about infectious causes, particularly in bilateral congenital cataracts. As Amanda alluded to, congenital childhood cataracts affect around about 200,000 children worldwide are blind associated with that. That's the current estimates. And we look at the incidence rates, it's around about 3 to 6 per 10,000 children in births. Usually bilaterals more common than unilateral cataracts, and most children identified before the age or develop their cataracts before the age of 1. When we look at lens embryology, it's important to kind of realize at which points children may become susceptible to developing congenital cataracts. So the lens really is starting to develop in that first month of life. You see the optic vesicle and surface ectodome developing around 22 to 27 days of gestation. And then by around about a month's gestation, the lens pit is starting to form and the optic cup is starting to form as well, or the optic pit. And then that pinches off just after 1 month, posterior aspect of the lens. And then the anterior equatorial lens epithelium starts to proliferate as well. And it's only the lens epithelium fibers, that proliferate over time, and that actually includes throughout the rest of your life, as those secondary lens fibers sort of develop. So that critical phase where lens development is happening is really in the first sort of 2 months of life of gestation. The causes of pediatric cataract, the list is quite long, and so it's important to be thinking quite broadly when you're presented with a child with cataract. By far and away, I guess the idiopathic category is probably the most common, but you need to be thinking about acquired causes of cataract in children, and particularly infectious causes, as well as syndromic type causes and metabolic, because these will potentially be associated with certain life-altering or life-threatening conditions. So things like rubella, as we talked about, the herpes group of viruses, as well as infectious things like toxoplasma and syphilis need to be considered. Idiopathic inflammatory conditions, juvenile idiopathic arthritis. Certain drugs can be associated with it. Thinking about galactosemia and galactokinase deficiency is really important. Calcium and phosphate abnormalities, as well as diabetes, high iron levels, Wilson's disease, or high copper levels. And it's really important to also be thinking about trauma, and certainly non-accidental injury is always something that we need to keep at the back of our mind, particularly in unilateral cataracts, where you don't have any particular cause. Syndromes are relatively more common in bilateral type cataracts, and always thinking about the association with other conditions which might affect the child's life, including renal diseases, skeletal diseases, and some of the neuromuscular diseases as well. So the conditions are quite broad. It's important to get a pediatrician involved in the assessment, particularly in children with bilateral cataracts, because of the broad associations with other congenital abnormalities. It's also important to realize that cataracts can be associated with other abnormalities in the eye, and looking for those things very carefully, either in the clinic or with an examination under anesthesia, is really important to rule out these other secondary associations, including retinoblastoma, particularly in kids with total cataracts, who always have a high index of suspicion for that. We often think about cataracts as unilateral or bilateral, and that's quite a useful kind of way to think about the way we might categorize the causes of a cataract. It's also useful to think about how we might think about the visual prognosis of cataract as well. In terms of visual prognosis, unilateral cataract, because of the risk of amblyopia, is often the worst visual prognosis. And in some places, we may suggest just leaving a unilateral cataract because the visual prognosis is so poor, and the intervention with surgery is unlikely to confer any visual benefit. So that's something that needs to be decided on a case-by-case basis. And certainly in late presentations of unilateral cataract, you may think twice about doing anything. The majority are certainly idiopathic, and it's important to also look for associated ocular abnormalities, of which persistent fetal vasculature, I would suggest, is probably the most common. As I said, always try and rule out the possibility of trauma, and particularly non-accidental injury in a child with unilateral cataract. Think about asymmetric bilateral disease, so looking for subtle features in the non-affected eye. And we also think about intrauterine infections, and rubella can sometimes present unilaterally, although I've not seen a case of that. In bilateral disease, the visual acuities outcomes are paradoxically better, and that's because of the amblyopia issue. The majority of bilateral cataracts so far are idiopathic, although next generation sequencing of genomes is sort of making that more, we're finding more and more genes associated with it, which I'll go into in a little bit. The majority of other cases that are non-idiopathic are familial, so that's why it's really important to look at parents. And parents may not know they have a cataract, and they might have some subtle lens opacity that's just not present, that they don't appreciate, which is phenotypically more severe in their child. So it's really important to look at parents and not take a very detailed family history. Chromosomal abnormalities are often associated with other significant systemic issues, and often they come presented as a referral from the pediatricians rather than coming as a primary presentation to the eye clinic, but sometimes that happens. Thinking about some of the craniofacial syndromes, metabolic disease is really important to exclude. We've briefly touched on that, as well as some of the renal syndromes as well, because that can certainly affect patients' life. And intra-intrauterine infections are more commonly likely to be bilateral as well. Again, some of the anterior segment issues, including aniridia and anterior segment dysgenesis, can also present with bilateral cataracts. So the morphology of a cataract can certainly give us a clue as to the likely underlying syndrome or cause. So that's why it's important to have a really good examination of the lens itself. And I've got a picture here that shows lots of different morphologies, and I'll briefly go through each of them. A total white cataract, I mean, there's lots of different causes of that, and generally any particular cause of a cataract can eventually cause a white cataract, but sometimes the more common causes are sort of autosomal dominant isolated cataracts as well. The posterior polar cataract that we can see here with a dense posterior polar plaque can be sometimes associated with Alport syndrome. The nuclear cataract here, which again often is inherited as a dominant condition or can be isolated. We see the lamellar type cataract as well, which often is an inherited form of cataract. After that is an anterior lenticonus, which we need to be thinking about Alport syndrome, which is one of the renal associated syndromes as well, which can also be associated with macular or retinal atrophy as well. So it's important to have a look at the retina. They can have hearing issues as well. So these children need to be worked up, certainly for renal disease as well. We have the classic oil droplet cataracts that we can see here in galactosemia. Interestingly, if this is picked up and the child's diet's improved to address that, then sometimes those cataracts will often resolve by themselves. So that's a very important one to pick up. We can see on the next picture is posterior lenticonus, which can often be an isolated phenomenon, but again can be associated with some of the renal syndromes, including Alport's or Lowe's syndrome. So it's important to look for renal disease and posterior lenticonus. This is a membranous cataract. Now that's basically where the lens itself has extruded, the lens substance has extruded, and all you've got is the posterior and anterior capsule sort of fibrosed together. Classically, it's described in Hallermann-Streiff syndrome and Lowe's syndrome, but certainly any advanced sort of cataract can do that. Even traumatic cataract can look like that. So it's not particularly pathognomonic, but it's more common in those syndromes as well. So thinking about that. We have the sunflower cataract here that we can see in high copper levels. So it's very important to check copper in that classic sort of syndrome. Usually we'll have a Kaiser-Fleischer ring where you've got the orange ring around the limbus. It's unlikely to see that as a congenital presentation. Usually we see that a bit later in life in children. We've got this is the less visually significant cataract called a pulverient cataract, if I'm pronouncing that correctly, which is a Latin word for basically dust. It's this fine pigment, sort of speckled appearance within the nucleus of the lens. It's often inherited in a dominant fashion. Often you look at parents and they'll have evidence of that cataract that they might not be aware of. Generally, it's not visually significant. It can become more visually significant later in life, but we often see it as a visually significant thing in kids. The next cataract is the pyramidal cataract, which is a type of subgroup of anterior polar cataract. It's often quite visually significant. It's a very dense, thick, fibrotic cataract, which we can see in aniridia is probably the classic thing that's been associated with as well. So always thinking about aniridia if you see that type of cataract. Aniridia spectrum can be quite varied. So it's just because you may see iris doesn't mean iris involvement. This is the next one's a very typical sort of anterior polar cataract, which is quite small and visually insignificant. often while the cataract is not visually significant, you need to think about refractive error. So often in these kids, you might see the cataract and think, oh, that's small, that's not causing a problem, but they've got quite poor vision. And generally it's because their refraction is quite different. So it's very important to refract these kids, because you'll often find, particularly in unilateral anterior polar cataract, that the refraction is quite different to their unaffected eye, and that can be driving the amblyopia. And what they need is glasses and patching and not a cataract operation. The next slide is, sorry, the next picture we see is, sorry, my mouse is very temperamental, is a classic Mittendorf dot, which we see as a feature in persistent fetal vasculature. It's just a little vestigial remnant of the fetal vasculature that's left over. It's completely benign and not visually significant. Generally, it doesn't progress at all. The next one is also a benign sort of remnant of lens development, which is called a sutural cataract. Often these don't progress. Sometimes they can, but it's not a visually significant cataract. It can be left alone. You don't need to remove that at all in children. The next one is a very difficult type of cataract for all pediatric ophthalmologists out there who've come across these. This is a persistent fetal vasculature or cataract, which we see persistence of the fibrovascular membrane at the posterior aspect of the lens. Often it can be associated with ciliary processes that you can see pulled in. The eye is often micro-ophthalmic, and these cause quite dense amblyopia and may have varying degrees of posterior segment involvement. And last but not least, we can see cataract associated with corneal clouding, which is the typical sort of phenotype of Peters anomaly, where you see abnormal neural crest cell migration, which causes the lens to sort of adhere to the posterior endothelium of the cornea to varying degrees. And you can see the left eye is quite completely opacified, and on a UBM on that eye, the lens was totally attached to the cornea, and there was cataract there. The left eye was less affected with no cataract on that side. This is by far no means a complete list of the types of congenital cataracts you see, but would probably be the more common ones we'd see. Just a brief note about fetal vasculature, just since we've discussed it. The fetal vasculature is a complex network of vessels that persist, that develops from anterior migration of the hyaloid artery through the primary vitreous towards the posterior aspect of the developing lens. There's anastomosis with the anterior tunica vasculosa lentis, which is also supplying over the iris, and that's connected with these iridohyaloid vessels. So when we talk about persistent fetal vasculature, it's a persistence of any part of this vascular network. And it can occur from complete persistence to just that tiny little vestigial remnant that we saw in that Mittendorf dot. When we see it, it's typically unilateral. There's only about 10% of kids you'd see with bilateral persistent fetal vasculature. The kids typically present with leukocoria. Glaucoma is really common, often because the anterior chamber is very shallow. They've got persistent vessels there. Visual outcomes are notoriously very poor. The rate of the presentations can be anywhere from very mild disease, as we have pointed out, to very severe presentations where the entire fetal vasculature is remnant. And you can have different parts of it. You can have a bit of posterior part of the fetal vasculature that persists, as well as anterior, or the whole lot, or just bits and pieces. There are systemic associations, and certainly conditions such as Norris disease, trisomy 13, and Walker-Warburg syndrome can be associated with these persistent fetal vasculatures, often bilaterally as well. They often can be a diagnostic dilemma due to the way they may present, because they may mimic retinoblastoma, Coates disease, that can look a bit like ROP, or retinal dysplasia that you see in Norris disease, and sometimes they can look like posterior inflammation as well. So it can sometimes be a difficult diagnosis to make. More subtle features that you might see on an eye, which may or may not be visually significant, which are important to sort of appreciate, are the particularly the anterior loops or the anterior iridohyaloid vessels that might persist, where you get remnants of that vestigially on the eye. And they clinically present as these iridolenticular adhesions, which have varying sort of appearances. They look quite pretty on a photograph, but visually completely insignificant. You don't need to do anything about that. Just take a photo and say that's looking nice. They can be quite dense though, so something like this can be visually significant. You don't always have to remove them, and there's a good case published by one of the ophthalmologists in New Zealand where they had a similar looking persistent pupillary membrane like this that they managed quite successfully with just mydriasis. And they developed excellent visual acuity of 6, 7.5 without the need to go in there and cut that out. So it's amazing what you can achieve with a bit of tropicamide. Just to reiterate the Mittendorf dot, which we discussed, but also at the disc you can see remnants with a Burgmeister papillae. So these are all features that would suggest perhaps some persistent fetal vasculature might be contributing to the cataract that might be before you. So what do we do when we see a kid with a cataract? Well, generally I'll just go to unilateral first. For the vast majority, unless they're sort of one of these mass bilateral cases, extensive investigation is usually not very helpful, nor is it necessary. They're usually idiopathic, or associated with some ocular abnormality that you can see. So extensively investigating them that you would with metabolic screening and infectious screening as well is probably not necessary. The bilateral cases are a different story, and it's certainly very important to take a strong family history, look at the parents, get the pediatricians and the geneticists involved if you can, as well as doing quite an extensive metabolic screen, karyotype if you can. Thinking about congenital infection as well is very important. I know in Perth, the infectious diseases people are very much against a tortured screen that we were told in our younger days, and really want directed investigation. So if you're thinking about rubella, doing a proper analysis of fluids or body sites for that CMV, for example, doing urine PCI testing rather than doing ad hoc serology is their preferred method. So it's important to have a chat to your infectious diseases team or what they would prefer rather than just doing writing on the request form tortures screen. It's important to look for the urine, looking for reducing substances. For galactosemia, should always exclude that, as well as looking for amino acids that we see in conditions such as Lowe's disease and Alport's. So when you look at that standard screening I've just described, it's very interesting that in unilateral cataract, you won't find a cause anyway, and you'll only find a cause in about 50 to 60% of bilateral cataracts. And torture screening has about less than 1% yield for the majority of bilateral cataracts. You think, well, why bother? And certainly I've sort of reduced the serology that I'm doing in bilateral cataracts and trying to be a bit more directed in the investigations. So what genes do we think about in cataracts? Well, there's lots of genes that have been associated with congenital cataract, over 52 at the moment. There's probably more now since this slide was made. By far and away, the most common are the crystalline genes, and they're associated, they're very important in maintaining lens transparency, and they're also important in density and maintaining, or giving the lens its refractive power. So abnormalities in those groups of genes, it's obviously associated with clumping of proteins and loss of transparency of the lens. Other genes that have been implicated include lens membrane proteins, transcription factors, cytoskeletal proteins, and a spatter of other sort of non-related type genes as well. The inheritance of these genes is quite variable, but most of them are dominant. So always look at the parents because that's going to give you the clue. Because the majority, as I said, are going to be somewhere in the family. And with the next generation sequencing technologies that we have, if you've got a family history of cataracts, you're going to be able to identify at least 60% of the disease-causing mutation. It's probably higher now as we're getting more information on that. So why is that important? Well, in terms of making a molecular diagnosis, it's important for giving the family a bit more information about the risk of developing cataract in any future offspring that they might have. It allows us to identify any associated known other anomalies associated with the gene. So in pre-symptomatic patients, you might be able to identify, for example, if they're going to have renal disease or cardiac disease earlier, which is very important in certain populations, and particularly metabolic disease as well. You can identify that earlier if you've managed to identify that gene in the child with cataract that you have. And it's also important, the knowledge is important in terms of developing gene therapies in the future. So for the future of therapies, what you don't know, you don't know. So understanding that is really important from that point of view as well. So how do we decide what makes a cataract significant? So it's the size and the location of the cataract. So if it's bigger than 3 millimeters, more posterior, more central, and more dense, it's likely to be visually significant. You want to look through the red reflex, and can you see it? Can you see it through? Can you see the red reflex through an undilated pupil? If you can't, it's probably going to be visually significant. Can you see the optic nerve and macula? And is there any significant refractive error associated with it? That's going to make it more visually significant. Cataracts are challenging in kids. They're technically more challenging. They're more likely to get complications. We're more likely to need surgery afterwards. The growth of the eye has to be accounted for as well, and it's really unpredictable. And visual rehabilitation is the biggest part of pediatric cataract outcomes in terms of whether or not we get a good vision or not, really. This is just a short video of how I perform congenital cataract surgery in infants. So this is a 5-week-old infant with bilateral congenital cataract. I typically use an AC maintainer and do a vitrectorexis and do, this is membranous type cataract, and use the vitrector to actually remove the cataract. It does it quite nicely and in quite a controlled fashion. You can use small incisions. I'm aiming to make the capsular opening at least 6 millimeters in size. You want to remove as much lens remnants as you can, which you can do with the vitrector, and just going onto the other side to remove as much epithelium, lens epithelium as I can. Make that rexus nice and wide. Otherwise, you end up with capsular phimosis, which is a bit of a pain. I leave most children, we leave aphakic, certainly if they're below the age of 12 months. Just because we have good access to contact lens rehabilitation here in Perth. Certainly if you've got less access to contact lenses, then primary intraocular lens implantation should be considered. We manage them with post-operative topical steroids and antibiotics. As I said, visual rehabilitation is really important. In terms of patching therapy, I prescribe for unilateral cataracts 1 hour per day per month of age until they're about 8 months. And then we patch for half of waking hours, and that's according to the infant aphakia treatment study protocol. We consider secondary lens implants later on. Usually in most kids who have using contact lenses, if they're managing well with that, I won't approach that until parents are keen. Often that's around about 18 months to 2 years of age, because kids are getting quite difficult to use a contact lens at that age, or around about school age. And we need to consider post-operative complications, including glaucoma, lifelong. When should we operate? Well, basically, it's the earlier the better. If you look at unilateral cataracts, there's a linear rate of decline in visual outcome the longer you leave surgery. There is a bit of a plateau in the first sort of 5 weeks of life in that first month, and then it starts to drop off. So ideally, at least if you can get it done by sort of 5 to 6 weeks, that's the ideal time. If you look at this, the study by Birch published in 2009, they looked at various post-operative complications. There's a cluster of glaucoma cases in those who were operated on before 1 month of age. And that's really where we've become a bit more circumspect about really operating on too early. And so that's where the idea of operating on kids after 4 weeks of age has sort of come from. And most of us would sort of delay surgery until at least a month before considering operating Particularly, so the earliest in unilateral, I would say I would operate around about 4 to 6 weeks. In bilateral, you've got a little bit more time because the vision doesn't drop off as much. But generally, at 5 to 6 weeks, I would do, or 6 to 8 weeks at the max. Before it starts to drop off, you get about a drop off around about 8 weeks. So there's a bit longer that you can wait. I typically do bilateral sequential surgery, so one eye at a time on the same day. Other colleagues would do a week apart, but you want to get the vision rehabilitated quite quickly in bilateral surgery as well. So glaucoma is the big worry in the earlier you go with cataract surgery. What's the rate of that? Well, if you look at the study by Sharon Friedman, published in the States a couple of years ago, we know that around about 20% of kids by 10 years of age will develop glaucoma after the cataract surgery. And that's much higher the younger that you do it and the smaller the cornea is. And that risk persists lifelong. So it's something that you need to be thinking about for the rest of the life. You can't discharge them from an ophthalmology clinic. They need to be monitored. When we look at this idea of glaucoma and when to do surgery, what to do with the surgery, we've talked about timing. The other issue is whether or not we use an intraocular lens. Certainly, there's 2 big studies that were published in JAMA Ophthalmology in the Lancet. One from the UK, which is the IOL under 2 study, which looked at various factors associated with the risk of surgery. It found that the older you were, the less risk you had of cataract, of developing glaucoma. It doesn't matter if it was unilateral or bilateral. And the smaller your eye, the more likely you were to develop surgery. If you had, glaucoma, and if you had a lens implanted, you were less likely to develop glaucoma in that study as well. Similarly, in the infant aphakia treatment study, it was not visually, clinically, statistically significant, but the probability of developing glaucoma overall was a little bit higher in the first couple of years of life. But then after that, there wasn't really much difference whether or not you use the contact lens or intraocular lens. So I think there's a lot of confounding in those things, and I don't think intraocular lens itself confers a risk of developing glaucoma other than parameters within the eye itself, I think. So should we put a lens in when you do your cataract surgery? What the arguments against it is, well, you shouldn't put it in because you can't predict what the long-term refractive outcomes are going to be. They're more likely to need additional surgery, and we'll look at some of their studies that have shown that. And if you use a contact lens versus using an intraocular lens, then in certain studies, the visual rehabilitation is comparable. The arguments for using it is, one, it avoids having to put a contact lens on. So if you don't have access to that sort of service, then this would obviate that need. It reduces the amblyopia severity if you're not corrected. And there's some evidence about reducing the risk of glaucoma, but as I pointed out before, that's a bit circumspect. So what do we do? If we're going to put the lens in, what are you going to choose? Interestingly, most of the growth in the eye is occurring by the first 12 months of life. So we know certainly within the first sort of 6, this is weeks after of total weeks of gestation. So birth is around about this age. They don't have this is not birth. So birth is around about 40 weeks. We can see 80% of the growth is done, but certainly by 100 weeks, which would be about a years of age, a good majority of the growth is done. In the infant aphakia treatment study, where they had patients below the age of 7 months, they aimed for about +6 to +8, and they got range of +5 round to -20 refractive result at 5 years of age. So it's very difficult to predict. The majority were slightly myopic, so there's a slight bias towards myopia with that sort of refractive aim, but it's very difficult to predict what that child's going to be at the age that they have the surgery if you do it young. So that's one argument for delaying intraocular lens implantation in primary cataract extraction. Just a brief note about the infant aphakia treatment study. This is designed to compare unilateral congenital cataracts, whether or not using a contact lens versus putting a lens in, intraocular lens was superior from a visual outcome point of view. They had 114 infants, and they were aged between 1 and 7 months, and they were randomly assigned to either get a contact lens or intraocular lens implant. They all had cataract surgery, and they at the time, they all and half received an intraocular lens at the time of implantation, and they looked at their visual acuity and looked at secondary outcomes, including complications and strabismus and other alignment issues. So if you looked at the visual acuity at 4.5 years of age in this study, intraocular lens, the contact lens group actually did a bit better overall. But the poor outcomes group was about the same, with about half having a visual acuity of 660 or worse, no matter if they had a contact lens or intraocular lens, but there was a bias towards better visual acuity in the contact lens group. In terms of post-operative adverse events, we saw that in the intraocular lens group, there was more reoperations, and that was mostly due to visual axis opacification. So proliferative lens material coming up behind the lens, requiring vitrectomy and lensectomy. So about 81% of patients who had an intraocular lens put in ended up with at least one adverse event that required either intervention or treatment with either surgery or medication. Glaucoma in itself was similar across the groups on that study. We'll just go past that. A similar study was the IOL-2 study, and just to reiterate, that was looking at children under the age of 2, and they looked at the risks and benefits of intraocular lens implantation in that group with either congenital or infantile cataracts, compared to treatment with either glasses or contact lenses. They had more children in that group. There's 256 children. It was an observational cohort study, so it wasn't a randomized controlled trial, so it's less power than the infant aphakia treatment study. And they basically excluded children with severe ocular problems. So it precluded the ability to implant IOL. So it was a fairly homogeneous group of congenital cataracts. Basically, they looked at visual acuity and complications after the congenital cataract surgery. Their main findings was that there was really no evidence that intraocular lenses are associated with better visual outcomes at 5 years of surgery, and that the reduced risk of secondary post-operative glaucoma following the bilateral cataract surgery wasn't reduced with intraocular lens implant. So, there was a significantly increased risk of needing further surgery. So, I mean, the take-homes from those is the problem with a lot of these trials is they're sort of a little bit biased in that children, particularly in the contact lens treatment groups, are often looked after pretty well. They're followed up quite closely. They have a lot of support, which may not be the case in your own center. So it's very important to be thinking about the socioeconomic status and supports that your child might have. And being aphakic may actually not be a visually ideal situation for the child in front of you, and putting a lens in might be the better option in terms of managing their amblyopia, and just accepting the risk that they're going to need further surgery, but at least their vision is going to be better. So, I mean, these studies help us realize that probably in the ideal situation, you're going to avoid further surgery with a contact lens, but the child has to be supported, and the family needs to be supported in that circumstance with all the issues associated with contact lens fitting and resizing and things. So that's really an important consideration to take in mind. So look, in summary, congenital cataracts are a heterogeneous mix of causes. You need to rule out the infectious causes and syndromic things. Genetic sequencing is going to help us in the future. Think about the earlier you can do the surgeries, the better, but you need to balance that with glaucoma risk, and generally after a month of age is the time you need to get in there. And think about delaying intraocular lens implantation if you can, and really, really push visual rehabilitation in these kids, because you can get the cataract out, but unless the child's patching and wearing the glasses or contact lens, particularly in unilateral cataract, they're not going to do very well. And these kids need to be monitored for life, and that's something that parents need to be aware of, that they can't just finish the eye clinic at the pediatric hospital when they turn 16 and then go off. They need to keep their eye watched, particularly for glaucoma. Thanks very much.
Okay, thank you, Dr. Clark, for an interesting and comprehensive presentation. I'm sure the audience has gained valuable knowledge from your lecture. Before we move to Q&A session, maybe you have any comment or suggestion for the case that presented by Dr. Lia? Dr. Clark?
I was interested, I mean, that's quite a late presentation for a bilateral cataract. Is there a formal child eye screening program in terms of vision in schools, or certainly newborn screening programs for cataract in Indonesia, or is it fairly ad hoc? What's the main barrier? Because it seems like to me that the main barrier was delayed presentation in that child with a lot of social factors going on.
Yeah, in Indonesia, we don't have any screening program for newborn screening, yeah, until now. So just make education program for pediatrician or general practitioner to screen baby born.
What would
Yeah.
be the typical age you'd find a child referred to you with cataract? Do they come to you fairly late?
Yeah,
Mostly.
okay. We have so many patients with congenital cataract in first month until 3 months old. Yeah, usually. Yeah.
Right. Okay, so you got some time.
Yeah. Okay. Thank you, Dr. Clark. Okay. I see that we have already we have some questions coming in the chat box. Okay. The first question from Dr. Ferdi. When should we extract the cataract? Should we do it as soon as we diagnose them, or are there any other consideration? And the second question, which should we extract the cataract first in eye with better or worse vision? Yeah, please, Dr. Clark.
I presume you're meaning in bilateral cataracts there. Look, generally, as I said before, I typically would like to extract the cataracts in the same operating session. And if I'm not able to do that, then I would usually separate them by less than 2 weeks. And I would do the worst eye first, and try and sort of rehabilitate that one as quickly as possible. In terms of when to do it, ideally from an amblyopia perspective, you'd want to get the cataract out as quickly as possible, but it's balancing that risk with glaucoma, which is typically highest in that first month. So generally, I get them out as quickly as possible after a month of age. Again, there's anesthetic risk associated with that, so you need to work out there's no other systemic or syndromic conditions or particularly cardiac issues that might make their anesthesia risk more significant. So that's that balance there as well. But generally, from an amblyopia perspective, the earlier the better, after about a month.
Yeah, okay, thank you. And the second question from Dr. Dianisa. Should like to ask Dr. Clark, is there a particular reason why the lens was sampled in order to find the causative microorganism? Is it part of the routine workup in cases like this?
No, not routinely. It's because the child didn't present it. It wasn't picked up in any other assays at all. So the nasopharyngeal swabs were negative, blood was negative, the IG. The serology wasn't contributing. It was a bit muddied by the maternal IgG levels as well, so it wasn't quite clear, and so that's the reason we did it with the lens material.
Regarding to Dr. Dianisa question, if you find patient with rubella positive for IgM, do you wait until the serology IgM subsided or doing surgery?
Well, I mean, the serology helps you with the diagnosis, but it doesn't tell you. I mean, at the end of the day, the surgery needs to happen because that's from a visual perspective. So, you wouldn't delay the surgery for the waiting for the serology to improve. You may go ahead and try and do some PCI to help with the diagnosis, which will give you a more definitive answer than the IgG. But yeah, no, you treat the cataract as quickly as you can.
Yeah. Okay. Did you find any differences between patient with IgG or IgM positive for no history of rubella? Is there any inflammation higher in patient
Yeah, I mean,
with
rubella is
rubella?
quite uncommon. Yeah, they certainly get more post-operative inflammation, and glaucoma is a really strong issue that you need to be aware of and watch for quite closely, as that child had developed quite within a month. His pressure had gone up and their eye had been growing quite quickly. So glaucoma would be the main thing. And obviously the vision's going to be limited by the degree of retinopathy they have as well. But these are kids that, I mean, they're going to be, this child had sensorineural hearing loss as well, so they're quite profoundly disabled if you can't get their cataract sorted quite quickly as well.
Okay, is there any additional treatment for the patient with history of rubella?
Unfortunately not.
To reduce the inflammation, maybe?
Well, just
After
watch
cataract
closely. I
surgery.
mean, often give subconjunctival dexamethasone at the end of a case, and you might, if they've got significant post-operative inflammation, treat them with oral steroids. But it would be on a case-by-case basis.
Okay. Okay. The third question from Dr. Iza. She found a pediatric patient, 8 years old boy with an acquired cataract due to steroid use. In case like that, when should we consider doing cataract extraction? Ideally, what clinical sign and parameters that we should look for during follow-up? Use cataract.
So, I mean, the first thing you need to decide is it visually significant? Because the 8-year-old boy might have a bit of mild cataract, and their vision may be 6, 9, 6, 7.5. I would leave a cataract like that. I mean, at the end of the day, you're trying to improve children's visual ability, and if you take their cataract out, they're going to be presbyopic immediately. So you need to be thinking about that, and they're going to be in bifocal glasses for the rest of their life. So that's the first thing: is the cataract visually significant? If it is, and the vision's down at least less than 6/12, then that's when you would consider doing the cataract extraction. At 8, they're less likely to be amblyopic from the cataract, but they can sometimes develop amblyopia. So it's really important to consider that. And certainly if you can thinking that there may be the cataract's dense enough to be causing amblyopia, then it's going to be visually significant anyway. And then you should take it out as soon as possible. Look, post-op, the main things you're looking out for is making sure they've got no signs of, there's no sign of any post-operative excessive inflammation. I presume if they're on steroids, it's because they had inflammation. And so they may have persistent inflammation. And the other thing is certainly ocular hypertension or glaucoma, making sure there's no signs of that developing. And certainly that would be a lifelong surveillance, and making sure you manage any refractive error and potentially looking out for amblyopia associated with that as well, particularly in a unilateral cataract.
Okay, thank you, Dr. Rak. And the last question in the chat box from Dr. Rico Wong. In terms of bilateral visually significant cataracts, does the pediatric cohort receive bilateral cataract surgery at the same time, or it is done as a stage patient?
Yeah, look, I mean, that's the surgeon preference. Certainly, the previous, in the past, most would prefer to stage it, and that's purely due to risk of endophthalmitis and worry about endophthalmitis because of bilateral surgery. I prefer to do bilateral sequential surgery on the same day. It doesn't mean I'm doing, so I basically treat each eye as a separate case, a completely different setup, different fluids with different batch numbers and all that sort of stuff to maximize the or minimize the risk of developing an infection, but it's done on under the same anesthetic. The idea being that you want to, for bilateral cataracts, you want to rehabilitate the vision as quickly as possible, and that even a week or two where you've got one eye that's seeing better than the other can have a lifelong impact on visual outcomes. So if you're able to do, and again, you're also reducing their exposure to anesthetic, and so one longer anesthetic is probably better than 2 separate anesthetics. That's my theory and the reasoning behind doing it that way. and have had good results.
Yeah, okay, thank you. Okay, for the last opportunity for Dr. Estu, any question or comment for Dr. Clark?
Thank you, Dr. Clark, for your comprehensive talk tonight, because until now, it is a challenging in maybe also in our hospital as a national hospital to treat the cataract associated with rubella syndromes. Many patients come late, especially in unilateral cataract. I mean, do you have any comments or suggestion? Because in our hospital or our Indonesia is access to contact lens is so minimal. So it is only to maybe high education people. So, but meanwhile, rubella patients come from low educated patients. Maybe what is the a comment or suggestion for patients with unilateral cataract and also in rubella syndrome due to the microcornea, so we cannot do IOL implantation to this patient.
They're really tricky patients. You're not alone. You're not alone in that. And generally, unilateral cataracts that present late in particularly in rubella type syndrome kids are going to do poorly, I think, no matter what you do. The first question you need to ask yourself is the child going to benefit from a cataract operation, or is it best to leave them alone? Particularly in parents who have poor access to being able to come in for regular follow-ups to look for things like glaucoma post-operatively. That's the first thing to sort of consider. Sometimes doing nothing is the better approach than just doing an operation for the sake of it, because you think that's what you can do. That's often the hardest decision to make, is to do nothing. In terms of visual rehabilitation, unilateral cataracts are very difficult. I mean, it's very difficult to rehabilitate those with glasses. The lenses are so asymmetric, and the kids don't like to wear them. And so really, you need to be able to have access to contact lenses. I don't know if you've got access to the sort of equivalent of Bausch & Lomb, the Silsoft type lenses, which are the soft contact lenses, which have very high powers. You can get up to +30s in those, which are very good. But again, they're quite expensive. So again, from a social perspective, it's difficult to access that. But I mean, at the end of the day, the best thing you have is glasses, and if that's what you have, then that's what you have to deal with. But it's about sort of managing the patient as well as the family, I think, and realizing if it's sometimes a bit futile. I know certain centers for unilateral cataracts in particular may suggest don't do anything at all. For the bilateral ones, you're generally a little bit better. Aphakic glasses work really well, and I often will have good kids who do really well with aphakic glasses in clinic here, because parents can't tolerate a contact lens. These eyes that are really small, it's very difficult to implant intraocular lens as a primary case, and I think I would avoid doing that in micro-ophthalmic eyes. Even if you could do it, jamming a lens in there is going to give them glaucoma. And that's going to be worse for them than leaving them aphakic. So I think going with glasses for these types of kids is the better way to go initially, and you can always put a lens in later on once their eyes are a bit bigger.
Okay, thank you, Dr. Clark and Dr. Dian Estu. Unfortunately, I have to stop this discussion. Once more for Dr. Clark, thank you for your insightful lecture, and also for Dr. Lia for the case presentation. As conclusion, early detection of vision problem in children is important, especially those related to cataract as a risk factor for amblyopia. And we have to perform optimal and comprehensive pediatric cataract surgery. And also for long-term follow-up is required after cataract surgery to evaluate the complication, visual rehabilitation, and also for the visual improvement. And make sure whether we have sufficient competence and facilities or not. We have a highly informative session today, and I want to thank everyone for your participation and thoughtful questions. Your engagement is what makes these webinars so valuable. We look forward to seeing you in future sessions. So for documentation, and please turn on your camera for all participants. Again, yeah. Dr. Miki, would you like to take our picture?
Yes, thank you, Dr. Julie. Before we conclude our sessions, I would like to invite everyone to open up your camera as we will begin our photo session shortly. Okay, I think I will begin now. Everyone give us your best smile. 1, 2, 3. Okay, second page. 1, 2, 3. Third page. 1, 2, 3. Okay, that will be all. Back to you, Dr. Julie. Thank
Dr.
you.
Miki, thank you for your kind attention and good evening. Thank you, Prof. Morgan and Dr. Anthony Clark, and for all
Okay.
participants here. Bye-bye.
Thank you very much.
Bye. Thank you.